Uh, Picture this scenario for a second. If you are a parent or, an aunt, an uncle, or really just someone who spends any significant amount of time around kids,
Yeah.
you have absolutely been in this exact spot.
Oh, yeah, definitely.
You're watching a child, maybe they're like 3 or 4 years old, and they're bent over, clutching their stomach. They are complaining of a tummy ache.
Right, the classic tummy ache.
Exactly. And your mind, completely understandably, jumps straight to the usual armless suspects. Like it's a passing viral bug, or maybe they ate entirely too much sugar at a birthday party.
Right, you think it's just one of those standard childhood rites of passage.
Yeah,
Yes.
exactly. You fully expect it to just, vanish by the next morning. But then the morning comes and it hasn't vanished.
Yeah.
And weeks go by and it still doesn't vanish. What if what you're looking at isn't a passing bug at all, but a literal structural breach in their internal organs?
Terrifying to think about. I mean, it completely upends how we approach pediatric illness.
It really does.
We are so used to childhood illnesses being transient, right? Like
Wow.
fevers that break, scrapes that heal, viruses that just run their course. Shifting your perspective from a temporary inconvenience to the reality of a chronic physical wound sitting inside a child's gastrointestinal tract, well, it is a jarring adjustment for any caregiver, or even for medical professionals.
And that adjustment is our entire mission today on this deep dive. We are exploring peptic ulcer disease, but we are looking at it strictly within pediatric patients. I think we really need to completely reset our assumptions right out of the gate here.
I agree. We have to wipe the slate clean.
Because we are so deeply conditioned by pop culture and old medical tropes to think of ulcers as an exclusively adult problem.
Yeah, for sure.
When I say the word ulcer, you probably picture a stressed out executive drinking their fifth cup of black coffee, right? Working an 80-hour week, clutching their stomach in a boardroom.
Yeah, the classic TV trope.
Yeah.
But the sources we are looking at today reveal a completely different, frankly hidden reality.
Yeah, this is a complex pediatric issue. It operates by its own unique rules. It features shifting symptoms that disguise themselves depending on how old the child is, and it even involves a genetic lottery that basically predestines some kids to suffer from it.
It's incredibly multifaceted.
Okay, let's unpack this. Because to understand what actually goes wrong, we first have to understand the normal, everyday anatomy of the gut. So what exactly are we looking at when we talk about a peptic ulcer?
Or to really grasp the pathology, we have to look at the overarching environment of the human gastrointestinal tract. Because every single day, every hour, there is a delicate, completely invisible balance of power happening inside the gut.
Okay, like a balance of what?
Well, it is a microscopic war zone. So
Mhm.
let's define the terms of this specific battlefield first. A peptic ulcer is fundamentally a breach of the gastrointestinal epithelium.
The epithelium, that's the lining, right?
Yeah, the epithelium is the innermost lining of the gut, essentially the wallpaper of the stomach and intestines.
Yeah.
But it's vital to note that an ulcer is not just a surface scratch.
Right, it's deeper than that.
Exactly. To be medically classified as a true ulcer, this breach has to dig deep. It extends completely through a layer of tissue called the muscularis mucosa, and it continues down to the foundational layer called the submucosa.
So it's not just peeling off the wallpaper, it's digging through the drywall and hitting the studs.
That is a highly accurate way to visualize it. It aggressively erodes the normal structural integrity of the gut wall. Now, we have to differentiate this true ulcer from two other terms that get thrown around in gastroenterology, which are an erosion and a perforation.
Okay, let's start with an erosion.
So an erosion is a simple, relatively shallow breach. It stays on that surface epithelial lining. It hasn't dug deep enough into the muscularis mucosa to earn the title of an ulcer yet.
So that's more like the scratch on the wallpaper.
Yes, and we often see erosions caused by acute temporary irritants like taking a harsh medication on an empty stomach or maybe just a brief bout with an infection.
Okay, that makes sense. But on the opposite, far more extreme end of the spectrum, you mentioned a perforation. And a perforation is the nightmare scenario, right?
Oh, absolutely. It is the ultimate failure of the gut's defenses. A perforation means the depth of the wound has completely breached the entire width and length of the gut wall.
Ow.
Yeah, it is a hole straight through the organ leading directly out into the abdominal cavity.
That sounds catastrophic.
It is. So a peptic ulcer sits precariously right in the middle, somewhere between a shallow erosion and a catastrophic perforation. And the reason this localized destruction happens all comes down to that balance of power I mentioned earlier.
The war zone.
Exactly. In the gastrointestinal environment, you have cytoprotective factors,
Yeah.
and you have opposing cytotoxic factors.
Okay, let me try to visualize this. Because I initially thought of a medieval fortress, but let's modernize it. Let's think of the stomach lining like the heat shield tiles on the belly of a space shuttle during atmospheric reentry.
I like that.
So, the gut wall is the fragile aluminum hull of the ship. The cytoprotective factors are the ceramic tiles, the cooling systems, the physical barriers keeping the ship from incinerating.
Right.
And the cytotoxic factors are the thousands of degrees of atmospheric friction and plasma just trying to melt through the hull.
The heat shield analogy works perfectly, actually, because we are dealing with intense, localized chemical burning. So let's examine the cooling systems first, the cytoprotective factors.
Okay, what are the tiles made of?
These are the built-in biological elements that actively protect the gut wall from its own harsh environment. First, you have a tremendously thick mucus layer.
Just a wall of slime.
Basically, yes.
Yeah?
But this mucus isn't static. It is constantly actively secreted by specialized glands embedded in the mucosa, so it creates this physical, highly slippery barrier. Second, woven into that mucus, you have continuous bicarbonate secretion.
Bicarbonate, like baking soda.
Very similar chemical principle, yeah. Bicarbonate is a highly alkaline substance. When it meets stomach acid, it literally neutralizes it on contact.
Oh.
So it acts like a localized chemical fire retardant deployed entirely within that physical mucus barrier.
So you have a physical wall of slime, and inside that slime, you have a chemical neutralizing agent. That's a pretty good defense system. What else?
Third, you have an incredibly robust mucosal blood flow. We often just think of blood as a transport mechanism, right? But here, it's a critical defense.
How does blood stop an acid burn?
High-volume blood flow ensures that the cells of the gut lining have a constant, massive supply of oxygen and nutrients. This allows them to stay metabolically strong and instantly fight off microdamage. And that leads directly to the final cytoprotective factor, which is the regenerative capacity of the gut mucosa.
Meaning it heals quickly.
Beyond quickly. The gastrointestinal tract has an astonishing ability to undergo rapid cellular mitosis, renewing and repairing its own cells continuously.
So the tiles on the space shuttle are constantly replacing themselves while the ship is in flight.
Constant. Those are your built-in defenses.
Okay, so if those are the tiles, what is the plasma? What are the cytotoxic factors trying to melt the ship?
The cytotoxic factors are the corrosive elements that cause cellular death and tissue degradation. High levels of hydrochloric acid secretion represent the primary threat.
Right, stomach acid.
Exactly.
Right.
But alongside that acid, you have high production of pepsin. Pepsin is a powerful digestive enzyme specifically designed to break down dense proteins.
Wait, hold on. Human tissue is made of protein. So if the stomach produces an enzyme whose sole purpose is to dismantle proteins, it's essentially producing a chemical weapon that targets its own structure.
Yes, that is the fundamental paradox of human digestion.
That's wild.
It is. And in addition to the body's own acid and pepsin, you have external cytotoxic factors. Certain medications can be massively destructive, specifically NSAIDs, non-steroidal anti-inflammatory drugs.
Like ibuprofen.
Right. And then you have biological invaders, primarily a highly resilient bacteria known as Helicobacter pylori, or simply H. pylori.
So putting this all together, if the body naturally produces this incredibly intense hydrochloric acid and these protein-digesting enzymes, why doesn't the stomach just digest itself on a random Tuesday morning?
Because in a healthy child, that balance holds perfectly. The thick mucus and the bicarbonate neutralize just enough of the acid right at the absolute surface of the stomach lining. This creates a safe zone.
So the acid is still there, just not touching the wall?
Exactly. The acid remains potent enough to break down a piece of chicken in the center of the stomach cavity, but it is chemically disarmed just millimeters away at the mucosal wall. A true peptic ulcer forms exclusively when this dynamic tips favorably toward the cytotoxic side.
The shield fails.
Yes, if the blood flow drops, if the mucus layer gets thin, or if the acid production goes into severe overdrive, the heat shield fails and the plasma melts through the hull.
That dynamic is fascinating. So if the balance is primarily tipped by an overwhelming amount of acid and pepsin, we have to figure out who is naturally producing too much of it.
Precisely.
Because if a 5-year-old child is coming into the pediatric clinic with an ulcer, we have to ask if they were simply born with a heavier cytotoxic load. I mean, they aren't stressed executives drinking coffee. They might just be biologically wired to produce too much acid. And that brings us directly to the genetic lottery of this disease.
It does. And to explore the genetics, we first have to draw a hard line between primary peptic ulcer disease and secondary ulcers.
Okay, what's the difference?
Well, secondary ulcers are largely what they sound like. They occur strictly secondary to another massive traumatic bodily event. We often refer to these as stress ulcers in the pediatric intensive care unit.
And to be clear to you listening, we don't mean emotional stress like worrying about a math test. We mean physiological systemic stress.
Correct. Severe, life-threatening physiological stress.
Yeah.
We see secondary ulcers in children who have suffered extensive body burns, severe head trauma, or kids enduring a sickle cell crisis.
So their body is just overwhelmed.
Yes. The body is thrust into such extreme systemic shock that the normal blood flow is violently shunted away from the gut to protect the brain and the heart. Without that blood flow, the cytoprotective defenses immediately collapse.
The heat shield loses power because the ship's main engine is failing.
That's the exact mechanism. But primary peptic ulcer disease is an entirely different beast. A primary ulcer isn't caused by a sudden trauma. It is usually driven by a chronic, underlying hypersecretion of pepsin, specifically in its precursor form, pepsinogen and hydrochloric acid.
So their stomach is just working too hard.
Yes, the child's body is simply manufacturing a dangerously excessive volume of its own destructive chemicals day in and day out.
And this is where the source material gets into territory that I found genuinely shocking. You look at a kid with a primary ulcer and you wonder what environmental factor caused this overproduction. But for many of these patients, the root cause was basically written into their DNA the moment they were conceived.
What's fascinating here is that the demographic and genetic linkages are incredibly specific. Clinical data clearly shows that pediatric patients presenting with primary PUD routinely demonstrate abnormally high levels of pepsinogen,
Which means?
which strongly correlates with aggressively high levels of hydrochloric acid secretion. But the really striking part of the research is how this combination heavily aggregates around one specific biological marker, which is blood group O.
Okay, I want to pause on that. Connecting a basic, everyday blood type, blood group O, to a significantly higher risk of having a hole burned into your stomach, that is a massive conceptual leap.
It sounds like a leap, yes.
I mean, we typically think of blood types strictly in the context of emergency transfusions or blood drives. We don't think of them as architectural blueprints for how aggressively your stomach processes food.
It really reveals just how deeply interconnected our genetic expressions are. The genetic markers that dictate blood group O do not exist in a vacuum. They are inherited alongside a cluster of other genetic tendencies.
Like what?
Specifically, a tendency for a significantly higher parietal cell mass in the stomach.
Parietal cells being the actual microscopic factories that manufacture the stomach acid.
Yes, exactly. So a child with blood group O may literally be born with more acid-producing factories than a child with blood group A or B.
Oh, wow.
Or they inherit a naturally higher baseline for pepsinogen secretion. Essentially, their genetics preload the cytotoxic side of the scale from birth. These specific children are walking around with a heavier, sharper battering ram before their diet or their environment even enters the equation.
That is wild. And the evidence doesn't stop at blood typing, right? The family history statistics laid out in the sources are staggering. This isn't just some vague, generalized risk.
No, the inheritance patterns are robust. If a child has a positive, direct family history of peptic ulcer disease, say, a parent or an older sibling has at their own statistical risk of developing the disease leaps to between 25 and 50%.
That's a huge jump.
It is. And the ultimate proof of genetic involvement comes from studying monozygotic twins.
Identical twins who share the exact same genetic source code.
Right. If one identical twin develops primary peptic ulcer disease, the risk for the other twin developing it is roughly 50%.
50%. It's a literal coin flip. But actually, let me push back on that for a second.
Sure.
If they have the exact same DNA and genetics are the primary driver, shouldn't the risk be 100%? If one gets it, the other should automatically get it right.
You're hitting on the core paradox of genetic predispositions. The fact that the concordance rate is 50% and not 100% proves two things simultaneously.
Okay, which are?
First, the genetic component is undeniably powerfully strong. But second, genetics alone are not enough to manifest the disease. The DNA loads the gun, but the environment, the lifestyle, or an external pathogen still has to pull the trigger.
Okay, so knowing that some kids are walking around genetically preloaded with these massive acid factories, how does this actually show up in the real world?
Well, that's where clinical presentation comes in.
Because the pediatric presentations of this disease are where parents and even general pediatricians have to be incredibly sharp. The symptoms we are looking for are not always what you'd expect. It is not just a kid complaining of heartburn after eating something spicy.
Far from it. We can start by outlining the general clinical manifestations, the classic textbook signs. The absolute hallmark symptom is pain, but it is a very specific type of pain.
Not just a general ache.
No, it is frequently described as a constant epigastric abdominal pain. Anatomically, that means the pain is intensely localized in the upper middle area of the abdomen, resting just right below the rib cage. In a subset of patients, it might present as periumbilical pain, radiating right around the belly button.
The sources place a huge emphasis on the specific timing of this pain. It's not just random throughout the day.
Right. The timing is a vital diagnostic clue. Nocturnal pain is considered a massive clinical red flag.
Meaning pain at night.
Yes, we are talking about pain that is so severe, it breaks through the child's sleep cycle and actively wakes them up in the middle of the night. This pain is usually non-radiating, meaning it stays stubbornly fixed in that central abdominal spot rather than shooting around to the back or up into the shoulders, which would suggest a different organ entirely.
And crucially, this pain is consistently aggravated by hunger. Wait, aggravated by hunger? That seems counterintuitive.
Why do you say that?
Well, usually if your stomach hurts, the last thing you want to do is put food in it. Why would an empty stomach cause more agony?
Think about the mechanics of the stomach environment we discussed earlier. When the stomach is completely empty, all of that highly concentrated corrosive gastric acid is just pooling and sloshing around. There's no food to act as a physical or chemical buffer.
Right.
So as the stomach naturally churns, that raw acid washes directly over the exposed nerve endings of the ulcer crater.
Oh, wow. So it's pouring lemon juice directly into an open cut.
That is the exact mechanism. That's why the pain is often temporarily alleviated or relieved by the intake of antacids, or even just eating food or drinking milk.
Because the acid has something else to do.
Exactly. By introducing food into the stomach, you give the acid a target. The acid begins breaking down the food instead of attacking the gut wall, which temporarily pulls the chemical fire off the exposed nerves.
That makes perfect sense biologically, even if it feels totally backwards behaviorally.
It does.
And beyond the pain, the sources list a whole cascade of broader symptoms. You have the standard gastrointestinal distress, right? Like nausea, vomiting, regurgitation. But then you transition into the far more alarming indicators, like hematemesis.
Which is the medical term for vomiting blood.
Right. And then hematochezia or melena.
Yes, and those last two require distinction. They both indicate significant gastrointestinal bleeding, but they look very different. Hematochezia presents as bright red blood in the stool, indicating a rapid bleed usually lower down in the tract. Melena, on the other hand, presents as dark black Tory stools.
Why does it turn black?
Because the blood originates higher up, near the stomach or duodenum, and it actually gets digested by the stomach acid as it moves through the tract, so it turns that dark carial color by the time it is excreted.
Oh, that makes sense.
You also see significant weight loss, and inevitably, the child develops anemia from the slow, relentless, hidden blood loss. The intensity of this symptom cluster can absolutely incapacitate a child, completely derailing their daily life.
But here's the major twist in all of this. Those are the general signs. The most critical part of this entire clinical picture, and the part that I think makes pediatric medicine so uniquely challenging, is that this disease completely changes its disguise based on the developmental age of the patient.
It absolutely does.
You cannot look at a 2-year-old toddler the same way you look at a 14-year-old teenager.
Age stratification is essential here. The disease presentation fundamentally morphs. In young children, infants and toddlers, they obviously lack the vocabulary to articulate, "I am experiencing localized epigastric burning."
Right, a 2-year-old isn't going to say that.
No. Instead, the ulcer masks itself as a generalized systemic distress. You see recurrent, seemingly unexplained vomiting. You might witness terrifying episodes of acute gastrointestinal bleeding. But the most insidious, subtle symptom in this age group is poor growth. They simply fail to thrive.
Think about the reality of that for a second. If you're a parent tracking your preschooler's milestones and they suddenly just stop growing, like they fall completely off their height and weight curves, your mind is going to race towards severe nutritional deficiencies.
Or rare metabolic disorders.
Right, or maybe a growth hormone issue. You are desperately trying to figure out why your child isn't thriving. You would likely never guess that a microscopic, highly localized wound in their stomach is causing such profound chronic metabolic stress that their body is literally halting its own skeletal and muscular development just to survive the inflammation.
It is a devastating masking effect that severely delays diagnosis. As we move slightly up the age bracket into the preschool age, the presentation shifts again. The pain becomes slightly more localized, often presenting as severe periumbilical pain right around the belly button. You also begin to see postprandial vomiting.
Meaning they vomit almost immediately after they eat a meal.
Yes. The introduction of food hits the severely inflamed stomach lining, and the organ simply rejects it. We also see a statistically higher risk of major hemorrhage or intestinal bleeding peaking in this specific preschool age group.
And then what changes when they finally reach school age and beyond?
Well, once a pediatric patient crosses the age of 6, their clinical presentation begins to mirror the classic adult presentation we discussed earlier.
Okay, so the more typical ulcer symptoms.
Right. They develop that highly specific epigastric abdominal pain. The pain starts waking them up at night. They figure out that taking an antacid or drinking milk makes it feel better. But even with these clearer signs, they might still present with an acute or chronic GI bleed, or they might just arrive at the clinic looking incredibly pale, chronically fatigued, and lethargic.
Because they've developed that iron deficiency anemia from bleeding out microscopically over the course of several months.
Exactly.
So the older they get, the more typical the disease looks. But in those critical early developmental years, it is a complete chameleon.
And we must emphasize that the worst-case scenario remains the same regardless of age. A full perforation.
Right, the nightmare scenario.
If the ulcer breaches the wall, it leads directly to peritonitis, a massive, acute, highly lethal infection of the sterile abdominal cavity. Alternatively, the ulcer can burrow so deeply backward that it physically aggravates adjacent organs, leading to conditions like pancreatitis, which presents with an incredibly deep-seated, agonizing pain that radiates entirely differently.
Okay, so we've established the genetics and the shifting symptoms. But these symptoms don't exist in a vacuum. A child might have blood group O, they might have the high parietal cell mass, but the severe pain and the eventual ulceration are triggered, aggravated, and weaponized by the child's daily environment.
Yes, the external factors are huge.
We need to look closely at the triggers and toxins, specifically diet, drugs, and social factors.
Dietary history is usually where parents focus first, but it is surrounded by a lot of misconceptions. It is a deeply held cultural belief that eating spicy foods physically causes stomach ulcers.
I mean, I think almost everyone grew up hearing some variation of, if you eat too much hot sauce, you're going to burn a hole in your stomach.
It's pervasive, but medically inaccurate. The clinical sources are unequivocal here. These foods aggressively worsen the condition, but they do not originate.
Okay, so the hole is already there.
Right. The primary ulcer, the actual structural breach in the heat shield, already exists. When a child consumes heavily spiced food or beverages containing high amounts of caffeine, the chemical properties of those items deeply irritate the raw exposed nerve endings inside the existing ulcer crater.
Ouch.
Furthermore, the sources point to beans, gas-forming foods, and heavily carbonated drinks as major dietary aggravators.
Okay, here's where it gets really interesting. I have to stop you there. Spicy food burning an open wound makes logical sense. But why would beans and soda be considered major triggers? Compared to acid and hot sauce, carbonation seems completely benign.
It comes down to simple physics and mechanical stretching. Beans, certain complex carbohydrates, and highly carbonated beverages cause rapid gas formation in the gastrointestinal tract. That trapped gas expands, forcibly distending the stomach and the intestines.
Okay.
Think of the gut wall like a balloon. If you have an open, inflamed microscopic wound on the rubber of a balloon and you blow air into it, physically stretching that rubber as tight as possible.
It's going to pull the edges of the wound apart.
Exactly. It mechanically tears at the ulcerated site. The pain from that stretching is excruciating. It's not a chemical burn. It is a physical, mechanical aggravation of the injury.
That sounds agonizing. So that covers the dietary aggravators. But what about the drug history? Because earlier, you explicitly named NSAIDs as a primary cytotoxic factor, meaning they actively cause the damage rather than just irritating it.
Yes, certain pharmaceutical agents actively degrade the epithelial lining. NSAIDs, nonsteroidal anti-inflammatory drugs, which include incredibly common over-the-counter medications like ibuprofen, are notorious in this regard. We also must evaluate the child's exposure to tobacco, alcohol, and the medical use of corticosteroids.
I really want to dig into the biology of how these specific drugs act as cytotoxic agents. We all vaguely know you shouldn't take ibuprofen on an empty stomach, but what is the actual mechanism? Why does a standard, incredibly common fever reducer structurally damage the stomach wall?
To understand this, we have to revisit our cytoprotective factors, specifically the secretion of the bicarbonate, and the thick mucus. NSAIDs work systemically throughout the entire body to reduce fever, inflammation, and pain.
Right.
They achieve this by chemically inhibiting a specific set of enzymes called cyclooxygenases, which produce prostaglandins.
Prostaglandins are the chemical messengers that tell the brain, hey, this ankle is sprained, make it swell up and send a pain signal.
Correct. But those exact same prostaglandins have a second, entirely different job in the stomach. In the gastrointestinal tract, prostaglandins are the specific messengers that constantly signal the mucosal glands to manufacture the protective mucus
Uh,
and to secrete the neutralizing bicarbonate.
Oh,
Huh.
wow. So by giving a child an NSAID to turn off the pain signals for a sprained ankle, you are simultaneously accidentally blocking the signals that tell the stomach to maintain its heat shield.
That is the precise mechanism. NSAIDs systemically inhibit bicarbonate and mucus secretion. They forcibly lower the stomach's defenses.
That's incredible. What about steroids?
Corticosteroids operate on a similar destructive spectrum. They physically thin the mucosal barrier over time and actively delay the cellular healing process of any minor existing microabrasions, which allows them to deepen into true ulcers.
And tobacco.
Regarding tobacco and nicotine exposure, and we mean even secondhand smoke inhaled by a child in the home, nicotine actively acts as a vasoconstrictor. It decreases mucosal blood flow.
It constricts the blood vessels, cutting off the supply lines of oxygen to the stomach tissue?
Yes, without adequate high-volume blood flow, the gut tissues simply cannot undergo the rapid mitosis required to repair themselves. So these drugs and toxins aren't just mildly irritating the stomach, they're systematically dismantling the entire biological infrastructure that keeps the stomach from dissolving itself.
That is a terrifying reality, especially when you consider how casually and frequently kids are given NSAIDs for minor fevers or aches.
It really is.
But the sources reveal an entirely different layer to these triggers, which falls under the social history. The medical guidelines require doctors to assess overcrowding in the home, poor hygiene practices, the family's water source, and their general socioeconomic status.
Yes, that's standard procedure.
But how does the number of people living in a two-bedroom apartment translate into a structural hole in a child's stomach?
It acts as a direct, highly efficient pathway for bacterial infection. Specifically, the Helicobacter pylori infection we flagged earlier.
Ah, H. pylori.
Right. H. pylori is a remarkably adapted bacterium that specifically thrives in the highly acidic, hostile environment of the human stomach. And it is primarily transmitted through the fecal-oral route or through the consumption of contaminated water sources.
So poor hand hygiene and questionable municipal or rural water sources are the physical delivery mechanisms.
Precisely. When you introduce overcrowding into a living space, the mathematical risk of pathogen transmission skyrockets. If one family member contracts H. pylori, inadequate hand-washing facilities, shared utensils, and dense living conditions make it highly probable that the bacteria will efficiently spread to the children in the household.
It just sweeps through the family.
Yes. Therefore, clinical data consistently shows that H. pylori infection rates are exponentially higher in lower socioeconomic demographics where systemic overcrowding is prevalent and sanitary infrastructure may be compromised.
Okay, so armed with this massive amount of background data, the history of the child's diet, the layout of their living environment, their genetic blood type risks, and a timeline of their highly age-specific symptoms, it's time for the pediatrician to actually step into the exam room and physically evaluate the patient.
The physical detective work begins.
Exactly. We're moving from taking a history to playing physical detective. What exactly is a doctor looking for when they perform a physical exam for suspected pediatric PUD?
Well, the initial phase is purely observational assessment. The physician is looking for overt signs of physical distress caused by chronic pain. A child harboring an active peptic ulcer is frequently observed guarding their abdomen, perhaps sitting hunched forward to relieve tension on the gut wall.
You can just see they're in pain.
Right. And the doctor will assess for severe pallor. Is the child's skin unusually pale? That is a primary indicator that they may be experiencing active hemianemesis, or that they are suffering from the profound anemia associated with a slow, chronic internal bleed.
Makes sense.
They also assess for systemic dehydration, which is an immediate consequence if the child has been suffering from recurrent postprandial vomiting.
And you're checking the baseline vital signs too, right? Like heart rate, blood pressure, respiratory rate.
Yes, checking for tachycardia or hypotension, which could indicate massive blood loss. And critically, in pediatric medicine, you take precise anthropometric measurements: height, weight, head circumference, plotted against their age.
Right, to see if they are growing.
Exactly. You are seeking the answer to the most fundamental pediatric question. Is this child biologically thriving? If their measurements show they are actively falling off their established growth curve, that is a massive, glaring clinical clue pointing toward a chronic, energy-depleting, inflammatory issue like PU.
And after observation comes the abdominal exam itself.
Hmm.
And there's one specific clinical detail detailed in the sources here that I find completely fascinating. It's referred to as the pointing sign.
Yes. It is a classic clinical indicator. The physician will ask the child to localize where the pain is coming from, but they give a very specific instruction. They ask the patient to point to the exact source of the pain using the tip of only one single finger.
I want to focus heavily on this because it highlights the profound, elegant utility of simplicity in physical medicine.
It really does.
If a child has a generalized viral gastroenteritis, like a standard stomach bug, or they just have trapped gas, and you ask them where it hurts, they will almost always rub the palm of their hand broadly over their entire belly. The pain is diffuse, it's everywhere. But if that child has a true peptic ulcer, that pain is hyperlocalized to the specific crater in the tissue. If they take one finger and point it directly and firmly into the epigastric region right below the breastbone, or occasionally the periumbilical region, that constitutes a positive pointing sign.
It's a great observation. It leverages the difference between generalized visceral pain and highly localized somatic pain. It is a beautifully precise, zero-technology clinical tool.
It's so smart. What else do they do?
Following that, the physician will perform deep palpation, checking for organ enlargement. They will palpate the liver, the spleen, and the kidneys to systematically rule out other massive systemic issues like organ failure or malignancies. They will also perform a digital rectal exam, looking for physical evidence of melena, that dark digested blood, or testing for microscopic hidden bleeding in the stool.
But the physical exam can also reveal a much darker immediate reality. What happens if the doctor presses on the stomach and realizes the ulcer has already gone all the way through the wall, if they are looking at a perforation?
If a perforation has occurred, the clinical picture immediately shifts from a chronic management issue to an acute, life-threatening surgical emergency. And one of the primary physical signs is respiratory. The child's abdomen completely ceases to move with respiration.
Wait, expand on that. When you breathe in, your diaphragm drops and your belly naturally pushes outward. It's involuntary.
It is, under normal circumstances. But when a peptic ulcer perforates, highly acidic gastric juice, undigested food particles, and aggressive bacteria violently spill out of the stomach and flood into the normally sterile abdominal cavity.
Oh, man.
Yeah, this catastrophic breach causes immediate peritonitis and intense, agonizing chemical and bacterial inflammation of the peritoneal lining that encases the organs. In response to this massive trauma, the body's central nervous system engages a radical, involuntary emergency reflex.
What does it?
The thick muscles of the abdominal wall rigidly and violently contract in an attempt to protect the severely inflamed organs beneath them.
It's essentially the body turning the soft abdominal wall into a literal rigid suit of armor.
It is clinically referred to as guarding or presenting with a board-like abdomen. The musculature clamps down with such sustained, rigid intensity in a desperate effort to minimize any microscopic friction or movement that might exacerbate the agonizing peritoneal pain that the abdomen actually stops rising and falling with the child's breaths.
The chest moves, but the belly is locked down like concrete.
Exactly. It is a stark, terrifying clinical sign that immediate aggressive surgical intervention is required to save the patient's life.
That drastically elevates the stakes of a physical exam. So assuming we aren't in a perforation crisis, the doctor has gathered their clues, they have the dietary and social history, they have the genetic markers, and they've completed the physical exam.
Right.
But before they subject a child to invasive medical procedures or radiation, they rely on a highly specific system of clinical weighting to make a confident initial diagnosis. Let's look at how they calculate this and how they rule out the imposters.
The clinical diagnostic criteria are strictly mathematically defined by pediatric gastroenterology guidelines to ensure precision. The symptoms are rigidly divided into major signs and minor signs.
Let's examine the major signs first.
There are only two, and they carry the most weight. 1, epigastric pain that has persisted chronically for 2 months or longer. 2, recurrent vomiting, strictly defined as occurring at least 3 separate times within a month.
So chronic, localized pain, and chronic vomiting. Those are the heavy hitters. What falls under the minor signs category?
The minor signs predominantly revolve around specific eating behaviors and secondary gastrointestinal distress. The list includes postprandial pain, or pain that actively wakes the patient from sleep, heartburn, oral regurgitation of acid, nausea, excessive belching, excessive bloating, or significant flatulence.
Why the excessive belching?
The chronic inflammation from the ulcer significantly alters the normal rhythmic motility of the gut. It disrupts how smoothly gas and food move through the system, causing gas to trap and violently reverse course.
Well, that makes sense.
Continuing with the minor signs, we have easy satiety.
Which means the child gets full incredibly quickly after eating only a tiny amount of food, because the inflamed stomach essentially refuses to physically expand to accommodate the meal.
Exactly. And the final two minor signs are periumbilical abdominal pain and, crucially, a documented positive family history of peptic ulcer disease.
Okay, so a doctor has these two distinct lists. How do they actually apply the clinical weighting? How do they do the math to reach a diagnosis?
A formal clinical diagnosis is confidently made if the patient's presentation mathematically meets one of three specific combinations. They require either one major sign plus two or more minor signs, or they must present with both of the two major signs simultaneously. Or in the absence of a major sign, they must present with at least four of the minor signs.
Let's map this out so we can see how this elegant logic works in a real-world clinic. Let's say a 10-year-old child has been complaining of sharp stomach pain right below the ribs for the last 3 months. Boom, that hits the threshold for one major sign epigastric pain lasting more than 2 months.
Right.
But they haven't been vomiting at all. So the doctor moves to the minor list. The parents note that the child can barely finish a quarter of their dinner lately. That's easy satiety, which gives us one minor sign.
Correct.
And during the history, it's revealed the child's biological father suffers from chronic ulcers. That is a positive family history, the second minor sign, one major, two minor. The clinical math adds up perfectly. The doctor has a formal diagnosis.
If we connect this to the bigger picture, it is essential to understand the biological imperative behind why the diagnostic criteria are structured with such rigid mathematical strictness.
Why is that? Why demand a 2-month timeline? Why require specific combinations?
It is purposefully designed to prevent doctors from misdiagnosing a simple, transient viral stomach bug while simultaneously ensuring they do not miss long-term, tissue-destroying systemic issues.
Like separating the signal from the noise.
Exactly. A child with acute food poisoning will easily vomit 3 times in a single day, but they will completely lack the 2-month chronicity. By enforcing a rigid timeline or demanding a combination of highly specific eating-related minor signs, the medical community effectively filters out the daily noise of childhood illness.
But the math doesn't just filter out stomach bugs. The doctors also have to aggressively filter out the imposters, other severe diseases that look exactly like an ulcer.
Yes, the differential diagnosis phase.
Yeah.
They must systematically rule out inflammatory bowel disease, or IBD, such as Crohn's disease.
How do they do that quickly?
A rapid physical differentiator there is examining the patient for perianal skin tags, or hemorrhoids, which can be strongly associated with IBD pathology, but are not typically a feature of upper gastrointestinal PUD.
Okay, what else?
They also must definitively rule out pancreatitis. As we briefly touched on earlier, the pancreas is a retroperitoneal organ. It sits deep against the back of the abdominal cavity. Therefore, pancreatic inflammation presents with a profoundly deep-seated pain that aggressively radiates straight through to the child's back, which feels fundamentally different than the localized superficial mucosal burning of an ulcer.
Okay, so the clinical math aligns. The differentials have been ruled out. The doctor is highly suspicious that a peptic ulcer is destroying this child's stomach, but at this point, they still haven't actually seen the wound.
Right, they need imaging.
They need to physically look inside the body to confirm the structural damage, measure its dimensions, and identify the exact biological cause. That transitions us into the critical phase of medical investigations and the gold standards of diagnostic imaging.
There are several established methodologies to visualize the hidden landscape of the gastrointestinal tract. Historically, and still utilized in specific resource-limited contexts, is the contrast radiograph, specifically known as a barium meal.
I think people might be familiar with this if they've ever watched older medical dramas.
Yes. The patient is instructed to drink a thick, chalky, highly radiopaque liquid suspension containing barium sulfate. This heavy liquid coats the entirety of the internal mucosal lining of the stomach and intestines.
Like painting the inside of the walls.
Exactly. When a high-resolution X-ray is subsequently taken, the barium aggressively blocks the X-rays, creating a stark, high-contrast silhouette of the gut wall.
And if there's an ulcer?
If a deep ulcer crater exists, the heavy barium liquid will physically pool and fill the hole, creating a distinct outward projection on the X-ray silhouette that confirms the breach. If the physician suspects the ulcer is located further downstream, beneath the stomach and the duodenum, they will order a barium meal with a follow-through, actively tracking the contrast dye over several hours as it transits through the lower system.
But at the end of the day, a barium meal is just giving you a silhouette. It's essentially a high-tech shadow puppet of the stomach. You can see the outline of the crater, but you can't see the tissue itself. That cannot be the definitive medical test in modern pediatric gastroenterology.
It is not. The absolute, undisputed gold standard for TUD investigation is the upper GI endoscopy.
Endoscopy.
Yes, this involves the direct, real-time, high-definition visualization of the esophagus, stomach, and duodenum, utilizing a highly flexible fiber optic tube equipped with a microscopic camera and illumination source.
Why does endoscopy hold the title of the gold standard? What elevates it so far beyond the X-ray silhouette?
Because an endoscope is not merely a passive camera, it is a dynamic intervention and surgical biopsy suite rolled into one instrument. With an endoscopy, the gastroenterologist can physically navigate to and visually confirm the exact anatomical site of the ulceration.
So they can see exactly where it is.
Yes, and they can visually measure its precise millimeter dimensions. They can thoroughly scan the mucosa to see if there are multiple clustered ulcers. Most crucially, they can instantly identify if the ulcer is actively hemorrhaging.
And what if it is?
If it is bleeding, they can pass microscopic thermal probes or clips through the working channel of the endoscope to cauterize or seal the bleeding vessel right then and there.
Oh, wow. So it's a treatment, too.
Exactly. Furthermore, they can visually evaluate the margins of the ulcer to assess if the tissue has undergone malignant transformation, meaning does the cellular structure look precancerous.
And finally, they can use it to determine the etiology, the actual root cause of the ulcer. And they do that by taking a physical piece of the stomach with them when they leave.
Exactly. Through the endoscope's tiny manipulators, they can easily snip a microscopic biopsy of the mucosal tissue surrounding the ulcer. That tissue is sent to pathology for intense histological examination under a microscope, primarily to hunt for the presence of H. pylori bacteria embedded in the tissue.
Okay, so endoscopy is undeniably the king of the diagnostic tests. But the clinical sources mention a battery of other investigations that seem a bit peripheral, almost unrelated to the stomach. They mandate checking serum electrolytes, urea, and creatinine, the EUCR panel. They order a full blood count, looking specifically for microcytic hypochromic anemia.
Which perfectly aligns with the pathology we discussed. Microcytic anemia means the red blood cells are abnormally small and pale. This is the absolute classic signature of profound iron deficiency.
From the bleeding.
Right. When a child has a slow microscopic bleed in their stomach for 6 months, they slowly deplete their body's entire iron reserve, resulting in this specific, quantifiable anemia on a blood test.
That makes total sense. But then there's this one investigation on the list that stopped me in my tracks, a comprehensive stool analysis to search for a hookworm infestation. Why on earth is a pediatric gastroenterologist looking for an intestinal parasite when they are trying to diagnose a stomach ulcer?
This circles back to the vital importance of treating the whole patient within the context of their specific geographic and socioeconomic environment. In certain global environments, particularly in developing nations, rural areas, or regions struggling with sanitation infrastructure, a child presenting to a clinic with severe chronic abdominal pain and profound microcytic anemia might not actually have a peptic ulcer at all.
They might have worms.
They might be suffering from a massive internal burden of hookworms.
Hookworms physically attached to the gut wall, right?
Yes, they lash onto the intestinal mucosa with their teeth and actively consume the host's blood. A heavy infestation causes a clinical picture that is virtually identical to PU: chronic abdominal distress, failure to thrive, and severe internal bleeding.
Wow.
Or, in a truly tragic scenario, the child's environment has exposed them to both H. pylori and hookworms simultaneously. A physician must definitively rule out parasitic infestation to ensure they aren't treating an ulcer while a parasite continues to bleed the child dry.
That is a wild diagnostic pivot, but it makes absolute logical sense. Now, there is one final imaging test mentioned in the sources, and this is reserved for the absolute nightmare emergency scenario we discussed earlier.
The perforation.
Right. If a pediatric patient presents in the ER with massive abdominal distension, severe gagging, a rigid, board-like abdomen, and the doctor highly suspects a perforation, what test do they order immediately?
They order a simple, upright chest x-ray.
Wait, I have to clarify this. They suspect a catastrophic hole in the stomach, which is deep in the abdomen, and their immediate response is to take an X-ray of the lungs and chest.
It sounds entirely counterintuitive until you understand the basic physics of human anatomy.
Okay, explain the physics.
The gastrointestinal tract naturally contains trapped gas. The abdominal cavity outside of the gut, the space holding the liver, spleen, and intestines, does not contain free gas. It is a perfectly sealed, fluid-filled vacuum. If the stomach wall violently perforates, the trapped gas instantly escapes the stomach and floods into the free abdominal cavity.
And because we all know that gas is lighter than liquid.
Gravity dictates the outcome. If you stand the child upright or sit them up, that escaped free gas will rapidly float upward, rising through the fluid of the abdomen until it hits a physical ceiling.
The diaphragm.
Yes, that ceiling is the diaphragm, the thick sheet of muscle that completely separates the chest cavity from the abdominal cavity. The gas gets permanently trapped right underneath it.
Oh, wow.
On a standard upright chest x-ray, the diaphragm is clearly visible. If a perforation has occurred, that trapped pocket of escaped gas shows up as a terrifying, stark, black crescent resting immediately under the diaphragm line. It is absolute, undeniable radiological proof that the gastrointestinal system has been violently breached.
Wow. The physics of the body betraying the injury.
Okay, so whether through the precision of an endoscopy, the stark proof of an x-ray, or the clinical weighting of symptoms, the doctor has finally confirmed the diagnosis. The biological heat shield has failed. The stomach is actively burning. How do they extinguish the fire? That brings us to the medical arsenal, the treatment modalities.
And looking at the protocols, this isn't just a matter of saying, take a pill and call me in the morning. This is highly calculated, highly targeted chemical warfare.
It requires immense precision. The pediatric medical arsenal for managing PUD is categorized into 4 primary drug classes: H2 receptor blockers, proton pump inhibitors, PPIs, cytoprotective agents, and simple antacids.
And in pediatric pharmacology, the mathematical rhythm of the dosage is just as critical to the ultimate success as the chemical makeup of the drug itself, right?
Absolutely. Let's start with the first line of defense, the H2 receptor antagonists.
What exactly are these and how rigid is the dosing?
The standard medications in this class are cimetidine, ranitidine, and famotidine. The dosing for a child isn't a standard pill size. It is calculated down to the precise microgram based entirely on the child's exact body weight in kilograms. But more importantly, the administration schedule is brutally rigid.
Like how rigid?
Cimetidine, for example, must be administered in a strict 8-hour rhythm. Ranitidine operates on a tight 12-hour cycle.
Think about the logistical reality of that for a parent. You are calculating exact liquid milligrams and waking up in the middle of the night to maintain a strict 8-hour rhythm for weeks. Why is the timing so unforgiving? What are these drugs actually doing inside the stomach?
The pharmacological mechanism is incredibly elegant. These drugs act as highly selective, reversible, competitive antagonists.
Okay, break that down for me.
To understand that, look at the parietal cells in the stomach, lining the microscopic factories that manufacture the hydrochloric acid. On the surface of these factories are specific locks called H2 receptors.
Okay, locks on the factories.
When the body's natural histamine binds to this receptor, when the natural key goes into the lock, it turns the factory on and acid floods out. An H2 blocker is essentially a chemically synthesized fake key.
It's a key that fits perfectly into the lock, but it doesn't turn.
Exactly. It physically occupies the H2 receptor, aggressively competing with the natural histamine. Because the fake key is jamming the lock, the real key cannot engage, and the volume of gastric acid production is drastically reduced.
But you use the word reversible.
Correct. The fake key doesn't stay in the lock forever. As the drug's half-life expires, the fake keys chemically degrade and fall out of the receptors.
And then what happens?
The moment those locks are open, natural histamine rushes back in, and the acid factories instantly power back up to full capacity. That is exactly why the 8-hour or 12-hour dosing rhythm is so monumentally strict.
If you're late on a dose.
If a parent misses a dose by even a few hours, the blockade drops, the acid floods back in, and it aggressively attacks the healing ulcer all over again.
Okay, so that's the H2 blockers. They jam the locks. But what about the really heavy artillery? The proton pump inhibitors or PPIs?
The PPIs represent the most potent, overwhelming acid inhibitors in modern medicine. Common names include omeprazole, lansoprazole, and Robisolol. Again, the dosing is hyper-calculated based on the child's weight.
And how do they differ from the H2 fake keys? Why are they considered heavier artillery?
If the H2 blockers are jamming the communication signal trying to turn the factory on, the proton pump inhibitors are essentially walking inside the factory and permanently destroying the manufacturing machinery.
Oh, wow.
They act as irreversible inhibitors of the H plus K plus ATPase enzyme system.
Let's translate that. What is the H plus K plus ATPase system?
It is the literal microscopic proton pump located on the inner membrane of the parietal cell. Its entire biological purpose is to forcibly bail highly acidic protons out of the cell and dump them into the stomach cavity to create hydrochloric acid.
And the drug breaks it.
When a child takes a PPI, the drug binds directly to this physical pump and permanently, irreversibly breaks it.
Permanently. As in that specific pump will never work again.
Correct. For the entire biological lifespan of that specific enzyme pump, it is dead. The parietal cell has to undergo the slow metabolic process of manufacturing entirely new protein pumps from scratch to resume acid secretion.
That's a huge delay.
That massive biological delay is why PPIs are so overwhelmingly potent. In fact, their acid suppression is so profound that the standard pediatric protocol is to initiate the child on a PPI, allow the gut environment to pacify, and then mandate a repeat endoscopy exactly 2 weeks later to visually confirm that the ulcer crater is finally beginning to granulate and heal.
That is incredible pharmacological power. Okay, so H2 blockers and PPIs are neutralizing the cytotoxic threat. They are shutting down the plasma. What about actively reinforcing the heat shield, the cytoprotective agents?
The primary heavyweight in this category is a drug called sucralfate. It requires a substantial dosage, often administered in a demanding 6-hour rhythm.
I have to say the mechanism of sucralfate is one of the coolest things in the entire source document. It acts like an internal, chemically triggered liquid bandage.
That is an incredibly accurate description of its pharmacokinetics. Sucralfate is ingested as a basic suspension. But when it travels down and actually reaches the stomach, it does something chemically unique. It heavily reacts with the ambient stomach acid.
How?
Specifically, the drug remains inert until it enters an environment with a pH aggressively lower than 4.
So it requires a highly acidic war zone to even turn on.
Yes. When it hits that intense acidity, the sucralfate molecules instantly polymerize. They violently cross-link and change their physical state, transforming from a liquid suspension into a thick, highly viscous, incredibly sticky gel.
And then what does the gel do?
Through electrostatic attraction, this gel specifically targets and permanently adheres to the exposed proteins leaking from the injured mucosa at the exact site of the ulcer crater.
It is quite literally a smart bomb bandage. It floats harmlessly until it detects the acidic fire, and then it physically spackles itself directly over the hole in the wall.
Precisely. It seals the breach, protecting the raw nerves from further acid attacks, while the tissue underneath gets the time and space to undergo mitosis and regenerate.
It is a brilliant mechanism. But, as with all powerful drugs, there is a vital, life-threatening clinical caveat here.
Yes. Sucralfate contains significant elemental aluminum in its chemical structure. Therefore, the sources mandate that it is strictly, absolutely contraindicated in any pediatric patient suffering from concurrent renal failure.
Because their damaged kidneys cannot filter out the heavy metal.
Exactly. A child with compromised kidneys cannot excrete the aluminum, leading to rapid, highly toxic heavy metal buildup in their bloodstream.
That is a critical safety detail. Finally, to round out the arsenal, we have these simple, classic antacids.
Yes, compounds like magnesium trisilicate. These do not alter cellular receptors, they do not destroy proton pumps, they simply utilize basic chemistry. When introduced to the stomach, they instantly chemically neutralize the existing pool of hydrochloric acid, converting the corrosive acid into harmless water and basic salts.
So they just offer rapid, localized, but highly temporary symptomatic relief. So we have built this massive, complex chemical arsenal to shut down the acid and patch the wall. But what if the fundamental root cause of the child's ulcer isn't just their body naturally overproducing acid? What if that breach is being actively, intentionally excavated by a biological invader?
H. pylori.
Right. Shutting off the acid isn't going to kill a bacteria. That requires deploying a specialized strike team.
Which brings us to the H. pylori hit squad. H. pylori completely rewrites the rules of engagement. We mentioned it earlier as a cytotoxic factor, but we need to deeply emphasize just how devious and damaging this pathogen is. H. pylori doesn't just passively sit in the stomach and cause mild irritation.
What does it do?
It actively chemically potentiates the hypersecretion of both hydrochloric acid and pepsin. It essentially hijacks the host's own acid factories and turns the child's weapons against them to clear out competing bacteria.
So before a doctor can assemble the strike team to kill it, they have to definitively prove the bacteria is actively present. So if H. pylori is physically hiding deep inside the stomach's mucus layer, I imagine a standard blood test isn't enough, right? Because a blood test just looks for antibodies, which only tells you if the child has ever been exposed to it in the past, not if the bacteria is actively digging into the stomach right now.
That is a crucial distinction. Serology blood testing is notoriously nonspecific for an active current infection. To confirm an active invasion, gastroenterologists rely on more direct methods. If they are already performing an endoscopy, they will physically biopsy the ulcerated tissue and test it directly for the bacteria.
And if they don't want to do an endoscopy,
If they need a non-invasive option, they utilize the urea breath test.
how does breath indicate a stomach bacteria?
H. pylori survives the stomach acid by producing massive amounts of an enzyme called urease, which breaks down urea into an ammonia cloud that shields the bacteria. The doctor gives the child a specifically tagged urea solution to drink.
Okay, and then?
If H. pylori is present, its enzymes break down the tagged solution, and the resulting chemical byproducts are absorbed into the blood, travel to the lungs, and are exhaled. The doctor literally detects the chemical exhaust of the bacteria in the child's breath.
That's wild. They can literally smell the exhaust.
Essentially, yes. They can also utilize a stool antigen test, aggressively hunting for microscopic fragments of the bacteria's physical structure shed in the feces.
Let's assume the test comes back overwhelmingly positive. The active bacterial invasion is confirmed. What is the treatment protocol? Because the clinical sources outline a protocol called the triple regimen therapy, and frankly, it sounds punishing.
It is highly aggressive. The standard first option triple regimen mandates the simultaneous administration of 3 powerful drugs: amoxicillin, which is a broad-spectrum penicillin-class antibiotic; clarithromycin, a potent macrolide antibiotic; and a proton pump inhibitor.
I want to focus on the sheer volume of this regimen. You have a young child whose stomach is already in absolute agony, and the doctor prescribes a massive dose of amoxicillin, plus a massive dose of clarithromycin, plus the heavy artillery PPI.
This raises an important question, doesn't it?
Yeah, exactly. Why are we using 2 completely different heavy-duty antibiotics simultaneously? Isn't one powerful antibiotic enough to kill a stomach bug?
Not this bug. H. pylori is notoriously stubborn, incredibly resilient, and deeply entrenched in the mucosal crypts. Using a single antibiotic often fails because the bacteria rapidly mutates and develops resistance.
So you hit it from 2 sides.
Using 2 entirely different classes of antibiotics attacks the bacteria's cellular structure from 2 completely different biological angles. Simultaneously, one might attack the cell wall, while the other attacks its ability to synthesize proteins. It creates an overwhelming crossfire that significantly reduces the chance of the bacteria surviving and mutating. The antibiotics are the specialized strike team sent in to eradicate the organism.
Okay, the dual antibiotic crossfire makes sense for killing the bug, but why include the PPI? The PPI doesn't have any antibacterial properties, it just destroys the acid pumps.
The PPI serves 2 critical synergistic functions in this regimen. First, by shutting down the acid factories, the PPI drastically raises the overall pH of the stomach environment.
Making it less acidic.
Yes. H. pylori prefers an acidic environment. Raising the pH makes the stomach incredibly hostile to the bacteria and actually makes the 2 antibiotics chemically more stable and far more lethal.
And the second function.
Second, and most vitally, the PPI stops the relentless acid from further degrading the ulcer. It creates a completely pacified, neutralized zone, allowing the gut wall to rapidly undergo mitosis and heal while the antibiotics conduct their war.
And I want to emphasize the grueling timeline of this regimen. The antibiotics, the strike team, are deployed in a massive 2-week blitz, but the PPI continues relentlessly for a full month. It's a marathon.
It truly is.
The bacterial infection might be completely eradicated in 14 days, but structurally rebuilding that deep crater in the gut wall requires a full month of absolute chemical protection.
Exactly. And the medical guidelines provide contingencies. If that first option fails to eradicate the pathogen, or if the child has a severe penicillin allergy, there are immediate backup plans.
Like what?
The second option swaps the clarithromycin out and replaces it with metronidazole, administered alongside the amoxicillin and the PPI. The third option drops the amoxicillin entirely, utilizing a combination of clarithromycin, metronidazole, and the PPI.
It is a rigorous, physically demanding, and frankly exhausting treatment plan for a family to execute. Getting a toddler or a young child to swallow multiple doses of incredibly harsh, terrible-tasting antibiotics and acid blockers every single day for weeks is a grueling battle of
It's
wills.
extremely tough on the
Yeah.
parents, yes.
But it is a battle that absolutely must be won. Because if this strict regimen is abandoned early, or if the initial diagnosis is missed entirely because someone assumed it was just a passing bug, the ultimate consequences are catastrophic. We must look closely at the final reality of this disease, the acute and long-term complications.
The complications of unmanaged pediatric PD are severe and permanently life-altering. We divide them into acute, immediate threats, and long-term chronic consequences.
We have thoroughly explored the primary acute threats, right?
Okay.
Perforation, the ulcer, burning a physical hole straight through the gut wall. That inevitably leads to peritonitis, the massive, overwhelming, and highly lethal abdominal infection.
Yes, and you have profound systemic anemia resulting from excessive, uncontrolled internal bleeding. You have severe hospitalization-level dehydration resulting from the relentless recurrent vomiting.
But there's one acute complication documented in the sources that is fascinatingly, tragically paradoxical. It's listed simply as obstruction.
Huh.
This initially confused me. How does an ulcer, which is fundamentally a hole, a complete lack of tissue, cause an obstruction, which is a physical blockage? It seems physically impossible.
It represents the dark paradox of the body's own healing mechanisms. When the body desperately attempts to repair a deep, highly destructive chronic ulcer, especially one located near the pylorus, which is the very narrow muscular exit valve at the bottom of the stomach, it rarely regenerates perfect, smooth, mucosal tissue.
What did it do instead?
In its rush to patch the hole, it lays down thick, dense, rigid scar tissue. This process is called fibrosis.
Okay, so it patches the hole with a thick scar.
Yes, but the ulcer isn't cured. So the ulcer breaks open again a month later. The body patches it with more thick scar tissue. Over years of this cyclical damage and frantic scarring, that dense fibrous tissue violently builds up.
Oh, I see where this is going.
Because the pylorus is already a tiny, narrow valve, this massive buildup of rigid scar tissue literally chokes off the passageway.
Yeah.
The body's desperate, repeated attempts to patch the breach end up building a solid wall across the entire channel, creating a complete physical obstruction that prevents any food from leaving the stomach.
Wow.
It requires major surgical intervention to physically cut the pathway back open.
It's the body accidentally boarding up the main gate of the fortress while frantically trying to patch a tiny hole in the wall. That is absolutely tragic. And the long-term chronic complications are equally devastating.
They are biologically profound. The chronic, unrelenting exposure of the fragile gut lining to inappropriate, massive levels of hydrochloric acid over the course of a childhood fundamentally alters the child's cellular biology.
How does it alter it?
In the esophagus, the chronic upward reflux of this excessive acid causes severe esophagitis, constant inflammation. Over years, the normal squamous cells lining the lower esophagus realize they cannot survive the acid burns, so they actually mutate.
The cells mutate?
They undergo metaplasia, physically changing their cell type to resemble the more acid-resistant cells of the intestine. This radical cellular mutation is a precancerous condition known as Barrett's esophagus.
The cells are literally morphing to survive, but in doing so, they become unstable.
Highly unstable.
Right.
And ultimately, chronic, unmanaged peptic ulcer disease, most especially when it is continuously driven by a long-term, deeply entrenched H. pylori infection, is recognized as a massive primary biological risk factor for developing gastric cancer later in adulthood.
Gastric cancer, resulting from a childhood stomachache that was dismissed or ignored for far too long. We really have to slow down the pace here to fully absorb the intense gravity of these physiological outcomes. But as we review the source material, there's one final complication listed.
Yes.
It doesn't involve cellular mutation or strictures or bleeding. It is simply labeled psychological.
It is often the most overlooked yet most pervasive complication in pediatric gastroenterology.
I think it might be the most heartbreaking reality of this entire deep dive. We are talking about a child, a deeply formative human being who has lived with chronic, agonizing, waking in the middle of the night abdominal pain for months or years.
And that takes a toll.
A huge toll. A child who has slowly learned to neurologically associate the basic necessary act of eating food with impending severe physical agony. A child who is watching themselves fall behind their peers in physical stature and energy because their body is starving itself to avoid the pain of digestion.
It's a heavy burden for a kid.
The sheer psychological toll of enduring chronic, severe pain on a rapidly developing brain, the deep-seated anxiety surrounding meals, the relentless stress of invasive medical interventions and grueling medication regimens, it structurally shapes their entire experience of childhood.
It permanently alters their fundamental relationship with their own physical body, with nourishment, and with the world around them. It profoundly underscores why early recognition, aggressive diagnostic testing, and highly precise pharmacological treatment are not simply about fixing a chemical hole in the stomach mucosa. They are entirely about rescuing and preserving a child's fundamental quality of life.
Which brings us to the end of our journey through this remarkably complex pathology today. We have traveled from the microscopic biochemical war zone of cytoprotective heat shields and cytotoxic plasma fires. We uncovered the genuinely shocking genetic reality that simply inheriting blood group O can heavily preload a child's baseline risk.
We really covered a lot.
We learned how to carefully decode the shifting, chameleon-like symptoms of a toddler failing to thrive versus an older child screaming in the night. We watched pediatricians act as physiological detectives, utilizing the simple brilliance of the single-finger pointing sign and the stark physics of an upright X-ray. And we explored the incredibly heady-hitting pharmacological arsenal, from perfectly timed reversible fake keys to the grueling month-long marathon of the triple regimen hit squad.
The overarching lesson embedded in all of this data is a demand for a profound, uncompromising respect for the unique complexity of pediatric medicine.
Without a doubt, keep this in mind the next time you see a child bent over with a severe, lingering stomachache. Being truly well-informed means understanding that children's bodies are not just miniature, scaled-down adult bodies. They do not process trauma or disease the same way, they certainly do not present symptoms the same way, and their internal fortresses possess entirely different hidden vulnerabilities.
And as we close this deep dive, I want to leave a final lingering thought to mull over, one that builds directly on the cellular realities we've discussed today.
What's that?
We know unequivocally that the gut mucosa possesses an absolutely incredible, almost miraculous natural regenerative capacity. It is biologically desperate to undergo mitosis and heal.
Right.
But given that powerful reality, what does the rising tide of our modern environmental stressors, from the highly processed, heavily altered foods we mass produce, to the increasing, often injudicious use of early childhood systemic antibiotics, to the persistent systemic reality of overcrowding in rapidly growing urban centers? What does all of that mean for the future evolutionary defenses of our children's internal heat shields?
That's a great question.
Are medical advancements helping them build stronger, more resilient walls? Or is our modern environment simply manufacturing heavier, sharper, and far more lethal battering rams?
It is a phenomenal question, and one that demands our continued attention. Until next time, stay curious and keep diving deep.